Non-immune mediated hemolytic transfusion reaction. After learning, students should be able to understand the pathophysiology of the reactions, explain causes and effects of the events, select an appropriate laboratory investigations to help diagnosis and monitoring of medical treatments, and the most important thing is to manage and select the best blood components for patients to prevent the reaction that may occur again. Transfusion reactions can be classified into two main groups, acute and delayed, depending on the onset of the reaction. Both groups are also divided into immune and non-immune mediated based on causes. Immune-mediated reaction means that patients produce autoantibodies specific to red blood cells, white blood cells, platelets, or plasma, while the non-immune-mediated reactions are caused by other factors. Non-immune-mediated hemolytic transfusion reaction is classified as acute reaction. Non-immune-mediated hemolytic transfusion reaction is defined as intravascular hemolysis of red blood cells during transfusion resulting from other causes but not antibody-mediated. Hemolysis leads to the presentation of signs and symptoms as of immune-mediated events, including hypotension and renal failure. Red blood cells can be raised in many situations, including duration of storage, temperature-related hemolysis, mechanical hemolysis, osmotic hemolysis, bacterial contamination in blood unit, inadequate deglycerolization of red blood cells, and coincidental hemolysis, which is a defect of red blood cells. First, duration of storage. Longer duration of storage before issuing is associated with increased hemolysis of storage-damaged red blood cells. Second, temperature-related hemolysis. Improper shipping or storage temperatures, as well as improper use of blood warmers or use of microwave ovens or hot water bath can cause temperature-related hemolysis. In transfusion site process, keyword of blood cold chain is implemented to confirm that all blood components will be processed, storage, transport, transfer, and prepare in an appropriate temperature required. Third, mechanical hemolysis. At the time of transfusion, using of small bore needle, roller pump, or employing a rapid pressure infuser can cause mechanical hemolysis. In addition, improper packaging is also cause mechanical hemolysis during shipping. Fourth, osmotic hemolysis. Osmotic of red blood cells is balanced in isotonic solution. In hypotonic buffer, water molecules will shift into intracellular compartment and cause swollen, leads to hemolysis. In another way, hypertonic solution cause water molecules move out of cells and cause cell shrinkage. So, infusion of hypotonic solutions or certain pharmacologic agents through the same tubing with red blood cells may cause osmotic hemolysis. AABB standards allow 0.9% sodium chloride to be added to blood during infusion. Another fluids need FDA approval for transfusion with red blood cells. For safe administration, red blood cells and dose agents should be given via alternate venous access locations. Next, bacterial contamination. In rare cases, hemolysis may be caused by bacterial contamination of red blood cells unit. However, patients may also experience hemolysis as part of their underlying disease process. So, laboratory investigation for bacterial contamination, including gram stain and hemoculture of blood remaining in units, as well as patient post-reaction blood sample, should be performed. Sixth, inadequate deglycerolization. Using of frozen red blood cells with incomplete deglycerolization may lead to intravascular hemolysis because remaining glycerol can destroy red blood cell membrane. Automatic washing machine is more suitable to deglycerolize compared to manual protocol, and personnel should be well trained in using red blood cells washing machine. Lastly, coincidental hemolysis. When both immune and non-immune causes of hemolysis have been excluded, the possibility of an intrinsic red cell membrane defect in patient or even in the transfused red blood cells should be considered. Red blood cells with these defects, such as G6PD deficiency, have increased fragility when challenged with particular stressors and may undergo coincidental hemolysis. Laboratory investigation for non-immune mediated hemolytic transfusion reaction, including: first, visual check for hemolysis by observing pink or red discoloration of serum sample. Compare between pre-transfusion and post-reaction. Second, screening for markers of neurohemolysis such as increased free hemoglobin, decreased haptoglobin, or increased lactate dehydrogenase. Lastly, rule out immune-mediated hemolysis by direct antiglobulin test, which should be negative for non-immune-mediated hemolysis. However, blood samples should be corrected as quickly as possible to avoid false negative in case that it is immune-mediated event. Other laboratory investigation to confirm causes of hemolysis should be performed, such as gram-negative and hemoculture in case of suspected sepsis, or screening of G6PD in donor unit if coincidental hemolysis is focused. When complication is suspected, first, stop transfusion. Second, provide treatments and supportive care, as mentioned in acute immune-mediated hemolytic transfusion reaction, to prevent hypotension and renal complications. As non-immune-mediated hemolysis is mainly caused from malpractice or underskill. For prevention, first, protocols for all aspects of manufacture and transfusion of blood components should always be followed. Second, personnel attendants should be well trained. Third, prompt recognition of non-immune-mediated hemolysis and robust root cause analysis may prevent additional occurrence.